All right, so as I stated, thank you for joining me. These are the stated objectives. And I should also state that even though I'm going to be talking about CDH program building, the concepts that I'm going to share with you are ones that could be applied across the board on other programs that you might want to consider, especially the high-risk ones. Those are the ones that really matter. Also, let me share with you some insights about something that I've learned only recently, and it's not exactly healthcare, but it applies, I think, to healthcare. Simon Sinek, who's a modern day author and a thinker and an inspirational speaker, has written books like Start With Why or Leaders Eat Last. But the one that I'm referring to that he's most recently written and I've been excited about is something called The Infinite Game. He describes the difference between finite and infinite games and how leaders who hope to lead well should recognize that the game that they are in might be an infinite game. What do you mean by that? Finite games are ones that we routinely see on TV or we engage in, something like football, basketball, etc. There's a start, there's an end, and we recognize there are winners and losers. Contrary to that, infinite games are ones in which there is no start, there is no end, and we get to play in it, but we are only a small part of it. The game goes on. And I would posit to you that healthcare, including taking care of babies with CDH, we are playing an infinite game. We are here for a short while, and we get to play in it, we get to participate in it. It's not a game that's ever going to end, and we hope to make each other better because we enjoy playing the game. And in sharing these insights that I will over the next 40 minutes, I hope to share with you the journey that Dr. Cass, Daryl, and I have shared as we played this game. We continue to play this game, and we will only seek to make each other better. Now, whilst this talk does include some data, it's less about p-values, and it's more about a journey and a story about how we overcame the challenges in trying to pursue our goal. With that backdrop, let me give you an outline of this slide of my talk. I'm going to talk a little bit about why organization of care is important, talk about the elements of a high-functioning program. I likely will talk about things that some of you have already heard before, but some might not have. We'll talk about the Donovan framework, phases of care, team composition, functioning. And towards the end, we'll talk a little bit about problem solving and QAPI, about how to identify and prioritize projects, engage team members. And I'll finally end with transport and CDH ECMO programs. Daryl, just confirm that I'm coming across okay? I don't hear you. Anyone, am I coming across okay?
Yes.
Okay, yes. Thank you. I should also like to share with you that I'm not going to be discussing any specifics about CDH management. That topic is far too vast to be completed in an hour. And for those of you who are interested, you could find out about what we actually do in terms of management by looking at the Baylor Neo guidelines, which Dr. Ali referred to. These can be obtained by free download from the Baylor Division website at that URL you see on the screen. It's currently downloaded, as you mentioned, in over 69 countries. So reasons to focus on CDH are high mortality, high morbidity, long length of stay, expense, and then great variation among centers. I'm probably not telling you anything new. So let me share with you some data that exemplifies why this is such a big problem. The next two slides talk about data from the CHNC. As you might know, the CHNC, or the Children's Hospital Neonatal Consortium, is a group of hospitals that are dedicated to improving the quality of care. Texas Children's, and I know Cleveland Clinic is part of that consortium. And the slides that I've obtained from Jackie Evans, who kindly shared this. None of these actually show individual hospitals, so it's de-identified data. On the left side of the screen, each one of these are individual sites. This is median length of stay, which one might imply that there's some babies who stay much, much longer because these are median lengths of stay. And you could see this is all the way up to 48, while some centers have much shorter median lengths of stays. On the right-hand side of the screen, this is mortality. And again, each one of these are individual centers. This goes all the way up to 48%, which is quite a lot. Again, you could recognize there's a great variation amongst the centers. Now, for the researchers amongst you, you would also recognize that these are not risk-adjusted data, which means that some centers probably take care of far sicker babies than other centers. Nevertheless, this is an enormous burden, and we need to address it. This slide shows the same mortality across time over the last decade. And gratifyingly, we do see a trend downwards where mortality is decreasing. Having said that, even as recent, still 1 in 5 babies will die. That's an enormous burden that we need to address. When we were building our program at Texas Children's during the time that Dr. Cass was out here, we looked to the Texas Birth Defects Registry to try and find out what the burden was. And you could see the data across time over the decade prior to us doing this and launching our program. And we found that over this time, there was a significant morbid mortality. And again, as recent as 2016, about 1 in 5 babies still died. When we asked the question about when did they die, we discovered that 25% of all the deaths actually occurred in the first day of life, 40% within the first 2 days, 50% within the first week of life, and then as much as 80% within the first month. These data have significant implications for trying to ensure that optimal care starts as quickly as possible after birth, with babies being ideally delivered in centers that are ready and able to care for them. Now, taking care of babies with CDH is expensive. I've got plucked just 2 papers from the literature about costs of care, and you'll see going back as far as 1995 and then about a decade ago, 2011, the costs range into the hundreds of thousands of dollars. Now, one might say those are reported in the literature. It might not give us a sense of what the actual burden is. So I chose to reach out to the FIS Center out here and got from them some data. Now, the FIS, that's the Pediatric Health Information System, has data reported from self-reported, I would say, from major children's hospitals. Likely many of you are at these centers, and these are data from 47 major children's hospitals for the last decade. Now, the x-axis is years over the last decade, and the y-axis is costs in millions. One would recognize that, again, these are average costs reported for each one of those hospitals, which means some of those costs are way higher per patient than others. Not surprisingly, if we attempt to correlate costs of care with length of stay, there is a positive correlation. The longer the patient stays, the more the costs that are involved. Now, these data are not broken down into what the type of the cost is. Unquestionably, there'll be some babies that have ECMO, some babies that have complications that stay longer. Nevertheless, the reason for the slide is to show you the burden in terms of costs, both now mortality, morbidity, and costs in terms of dollars, all of which suggests that we need to be focusing on this topic. So with that backdrop, let me share with you how we can jump into and actually improve the system. For some of you, none of this is going to be new. For others, you might take away some thoughts that might actually help in making changes to the way you conduct care. Surprisingly, the solution that we seek was actually first conceptualized in the 1960s by a physician, economist, and a health services researcher, Abidis Donabadian. Donabadian proposed in the 1960s that to improve care, we need to first work on the structures of care, then the processes of care to be able to garner good outcomes. This is important because this implies that the institution and leaders need to focus and help to make things happen. Oftentimes we get challenged because we feel that improving care and the goal that we seek is way too far away out of our reach. The important thing is that we need to start right where we are with what we can do when we can. We might begin with envisioning what the transformational goal is, where we want to head to, ask ourselves and motivate ourselves that working towards that would actually help, and try to see what the goal might be if there were no barriers, and ask ourselves what value we would bring to the organization if we actually embarked on this. This transformational goal is something that's a compass that will help guide us. It's not something that we might see immediately, but it needs to be something that we can all work towards. It's the big picture, the end result. So the question is, how do we achieve that? This slide that I borrowed from Brent James highlights a philosophy that might actually help us in healthcare. Chairman of Sony, Akio Morita, said, "A company will get nowhere if all the thinking is left to the management." What Morita was suggesting that the fundamental knowledge about what improvements need to be made, how things work, actually resides with the people, not with the top leadership. This is especially true of hospitals, as healthcare processes are very complex. The frontline worker, the nurse at the bedside, the respiratory therapist, the nurse practitioner, the physician surgeons, they're the ones that actually see what's happening, and they possess the fundamental knowledge that needs to be used to make change. The question is, how do we actually tap this frontline knowledge? How do we make it happen? For leaders in the institution, you do this by communicating the vision, the transformational goal that we want to get to, and then providing the tools to make things happen. Tools might be things in terms of support for education, consultation with experts, ways to facilitate the time and the budget to make time for the frontline workers to engage in these activities, then coordinate the teams, and then sometimes it might need to move barriers to improvement, and that can only happen from top down. And then celebrate with the teams the successes that will inevitably follow as we make these changes. So let's align this framework with quality improvement. I'll use the VA Quality Scholars model for improvement. This is an offshoot or a development of the IHI's model for improvement. And we begin by first defining a purpose, assembling the team before tackling the problem that we wish to tackle. Applying this framework to CDH, we might state our purpose as wishing to improve the quality of care across all aspects of CDH care, which begs the question, how do we break up this into tasks that we might actually work on? When we think about CDH care, we might consider it in phases. Before the baby is born, whilst the baby is being born, the initial hospitalization, and then the post-discharge follow-up. Each one of these are important, and each one of these need to be worked on separately. What Dr. Cass and I delved into was the center portion of it, working on both the delivery room stabilization and the initial hospitalization as we embarked on this journey. To vision, if we wanted to do that, our CDH program needed a personnel of core team members, neonatologists, pediatric surgeons, other specialties. We needed guidelines of care, optimal processes before we could discharge a patient for follow-up care. To build the right team, it's important to choose team members that share a passion for the project, ones that are respected, dependable, and those who might facilitate psychological safety. This last bullet is actually an important one, and I'll expand on that in a moment. Next, we need to define roles and responsibilities, and then create a shared understanding of the team goal. To define the purpose, it's very important to assemble a multidisciplinary team. For CDH, that might include neo, pediatric surgery, MFM, pulmonary hypertension. Next, develop program statements that include a mission, vision, values, and then create an call to action plan that includes regularly scheduled minutes, timelines for deliverables, and resources needed that we would ask from the administration to make things happen. And I'm going to share with you in the following slides how we did this at Texas Children's, and hopefully share something that might be of insight for you to take away to do something similar. As an aside, all of this is not difficult. And I quote, paraphrasing from multiple QI thought leaders, to improve global health today, more than new discoveries, we need better application of known discoveries. In short, what this is saying that we already know what needs to be done. We just need to be able to apply it and apply our knowledge better. So let me share with you the Texas Children's experience and what we did over this last maybe 5, 6, 7 years. We started with initial multidisciplinary leadership that consisted of neo, pediatric surgery, and MFM. Dr. Cass was my partner in this, with Dr. Belfort on the maternal fetal side. The program statement was next. We developed a mission, vision, values statement and a call to action plan, and I'll share that with you in a moment. We had multidisciplinary team meetings with our EBOC, that's the Evidence-Based Outcome Center representatives, and we created a list of PICO questions. You're familiar with PICO. And then we reviewed the published literature and available guidelines to decide what we wanted to abstract from those published wisdom. We created an intranet SharePoint site for folks who could not come to all of the meetings so that they could participate and still collaborate. In our initial phases of guideline development, we reviewed 154 studies and our guidelines to vet a total of 23 PICO questions. And over the span of 15 meetings, we developed our CDH guidelines and algorithms for delivery room management and for the inpatient management that we currently follow today. The EBOC developed materials are hosted currently on the hospital's intranet site, whilst laminated copies of the algorithms are also prominently displayed at patients' bedsides, and they serve as ready reminders and references for care teams. They also serve as a ready reference for trainees. Texas Children's, like many of your other centers, might also train pediatric residents, nurse practitioner trainees, neonatology fellows, pediatric surgeons, etc. So that serves as well as a reference. Whilst the core team was working to build the program, Dr. Cass and I, as representatives of the leadership team, shared our deliberations with the division at large, including the vision, mission, value statements. Let me delve into that and show you a brief of what we shared with them that guided our activities. We had a vision to be and have a preeminent CDH program with excellent high-quality care and to conduct innovative collaborative clinical research. The lower half of that slide, we did envision at that time to have a single program coordinator. In transparency, I should say that never actually did happen. We discovered later that that role could be facilitated by different people and is currently being facilitated by different people. As a mission, and this was a guiding compass, our mission was to provide a high-quality, consistent, evidence-based care for fetuses, neonates, children with CDH, across the spectrum. And for us to work well together, we chose the following core values: teamwork, integrity, and innovation. Now recognize different teams might choose different things as core values, mission statements, and visions. These were ours. In terms of management, we wished that daily interdisciplinary care be conducted by core groups of clinicians, including neonatologists, pediatric surgeons, nurses, respiratory therapists, etc., all using evidence-based clinical guidelines, which we then had to create with a specific attention to nutritional intake with oversight by dedicated dietitians. We recognized that if babies didn't grow, they were not likely to leave the nursery. In terms of program design, the program we wanted to be multidisciplinary across the board with personnel. We had paid attention to physical location with geographic cohorting, and I'll share that with you in a moment. Different work processes that guided our rounds, handoff transitions, guidelines and protocols, and education of staff, not to mention metrics to know how well we are doing. The TCH Experience, as we built this, was divided into phases, as I described, of review of the literature, starting with the phase that involved the delivery management and the inpatient management, and we've created guidelines for how we manage all of this. Simultaneously with creating the guidelines, we began Thursdays at 3 interdisciplinary CDH rounds in November of 2015. That phrase was a Dr. Cass phrase that has stuck. CDH rounds Thursdays at 3 included multidisciplinary discussions with a whole host of different providers. We initially were doing them weekly all the way until the pandemic hit, and since then we've gone to virtual and bi-weekly. During these rounds, we'd review, and we still do, admitted patients, anticipated patients, and we also receive updates of patients that are seen in the follow-up clinics. The picture on the bottom left is one from 2015 December, shortly after we began those rounds. I see a much younger Dr. Cass there. Thursdays at 3, these are the data of attendance. The slide depicts attendees since 2015 November, and they were wildly popular then and even now, with a lot of discussion, and they are actually very useful for trainees who get to ask questions about care that they might not necessarily have asked in a different forum. As we built the program, we also took the opportunity to build in many QI change concepts, some of which are highlighted on a couple of these slides. Eliminate multiple entries, handoffs, doing tasks in parallel. With the advent of the electronic medical record, there's many ways that these could be done. Standardization of care using guidelines and using order sets helped. Designing systems to avoid mistakes in the first place are vital. Let me share with you something about bringing teams together. To find the staff to care for these critically ill cohort, we followed a guiding principle that was stated in what might be considered a children's book and attributed to Anton Saint-Exupéry. If you want to build a ship, don't herd people together to collect wood and don't assign them tasks and work, but instead teach them to long for the endless immensity of the sea. What this means that if we were to find people who wanted to build our program, we wanted to find people who would wish to work with us on this high critically ill cohort. To do that, and enunciating the points mentioned in the previous slides, we started with admitting babies only to one pod in the nursery, in our 75-bed nursery, to the C pod. We admitted them only to one team, that's the orange team, which is one of 5 NICU 4 teams. Once admitted, the baby stayed on the same team. That eliminated the handoffs that go in when a baby gets transferred from a critically ill side to a step-down level 2 area. Ironically, the CDH babies are the only ones at Texas Children's currently to stay on the same team from admission to discharge. It actually helps not only with patient care, patient flow, planning, family satisfaction, a whole host of things. From 2016 July onwards, the team itself was staffed by the neo-ECMO clinicians mainly. The surgeons already had a core group of surgeons who took care of these patients. I recall there were 4, and now we've got 5 surgeons amongst the many surgeons at Texas Children's. For babies who did end up on ECMO, we solicited the help of the hospital's transfusion medicine team. So that restricted guidance for coagulation management to a small subset of physicians to help care for these patients. Coagulation management for babies on ECMO can be challenging at best of times. Now, meetings. Let me take a side note out here. To make things happen, not only the bedside work needs to be done, but we need leadership to facilitate that care is done appropriately and caregivers have the knowledge, skills, and abilities to take care of these patients. In his book, Death by Meeting, author Patrick Lencioni describes 4 types of meetings for which I've adapted to our purpose. His book refers largely to the business world, but I think there are things that we can take away. Amongst them, they're the daily check-in, which is a quick 5 to 10 minute meeting for daily shared activities, the weekly tactical, the monthly strategic, and then the quarterly, half-yearly, the annual review. The less frequent meetings are also important because they give us the opportunity to review metrics, discuss strategies, and plan team development events, including education. At Texas Children's, we actually have the following meetings. We currently have a daily 7:30 a.m. check-in where we discuss all surgical patients and babies who might have CDH and on ECMO. This is in addition to the daily work rounds that we conduct between 9 and noon. We then have bi-weekly CDH interdisciplinary rounds that I alluded to, this Thursdays at 3. We also have monthly CDH ECMO leadership meetings, and then some ad hoc meetings. Ad hoc meetings might be called by the Orange team attending or somebody who's planning for the care of a baby who's likely to be born at a different time, so we can come up with a consensus about how to care for this patient. Such discussions also help with the delivery room planning, especially for those babies who might not have a huge survival chance. It allows us to work with families to make sure that we deliver care that is family-centered, yet being mindful of the opportunity to care for the babies who might survive. And then we also have similar ad hoc meetings for group consultation for the management of critically ill CDH and/or ECMO patients. And these often are called by either the team leadership or by the Orange team attending. When we've got babies on ECMO, we'd have a daily 1 a.m. educational meeting for trainees, a daily 10 p.m. meeting, night rounds for clinical care with the clinician at home, surgeon at home, as well as the bedside providers. We have got monthly ECMO conferences where we talk about topics and it's largely educational. Biannual wet lab simulation training and an annual fellow boot camp in terms of training. Now, in addition to the meetings, we need to work as a team. In his book, The 5 Dysfunctions of a Team, Patrick Lencioni also shares how teams need to work well, need to have certain attributes. There needs to be a basic willingness to trust each other This trust is important because that helps to have healthy conflict when we disagree on a particular topic. This healthy conflict is required for problem solving. Without problem solving, there's less likely to be commitment between team members for a shared vision or a goal. If there's less commitment, it's unlikely that team members are going to hold each other accountable. And if team members don't hold themselves and each other accountable, it's unlikely that we would get the results that we need. To be results focused, we need to start with trust, healthy conflict, commitment, accountability, and a results focused mindset. Conversely, if there's an absence of trust, there's a fear of conflict, a lack of commitment because nobody wants to question each other. We avoid accountability both in ourselves as well as each other, and it results in us less likely to get the results we desire. Now, not surprisingly, with many well-intentioned, strong-minded, strong-willed individuals at Texas Children's, myself and Daryl Cass included, we too had our share of challenges as we built our team. And to build a team, we had to come together to affirm our principles of practice and develop rules of engagement that we would agree to. Recognizing that conflict can be an inherent part of teamwork, we sought speakers like Eduardo Salas, a Rice University professor and a teamwork expert who works with the space program and with astronauts, who had 30 years of experience in team performance research, and invited him to come join us and share his insights. Eduardo Salas shared with us that it took more than having the right people with the right knowledge, skills, and abilities for the job. He listed 7 C's of teamwork: capability, cooperation, coordination, communication, cognition, coaching, and conditions. And he asked the question of us, where were the opportunities that we had for improvement? And what could we do to make the team work better? He had us question what we could do. What we discovered was that non-clinical tasks and non-clinical venues actually help to build camaraderie that was needed for folks of different disciplines to work together well. We had on-site and off-site events for team building. Amongst the pictures you see there are tasks given where the individuals at the table are a mixture of nurses, nurse practitioners, neonatologists, physicians, etc., working together at a mundane or what might be considered a child's task, a play task, but enjoying the activity and building that camaraderie. In short, if you want to build a high-functioning program, begin by recognizing that it's challenging, but take the time to work on the teamwork first. Identify the dysfunctions amongst the team members that need to be addressed. Sometimes it's challenging to build consensus. How does one do that? In this case, taking a page from a book, Getting to Yes, we need to learn to separate the people from the problem and to focus on interests, not positions. We need to work together to invent options of how to solve the problems, and then insist on using objective criteria to discover what works and what doesn't work. By doing so, you could reach consensus in what you're attempting to do. We used consensus building as we actually deliberated on our metrics. We started with a long list of metrics where everybody wanted their favorite metrics to be added to land up with a very short list that we finally decided on. Up till now, I've spent much of the time discussing inpatient coordination of care. Let me touch upon briefly on the prenatal aspect and then the post-discharge phases. Early multidisciplinary care and evaluation is ideal, and this should involve multiple disciplines that are likely to be involved in taking care of this baby. And getting MFM, pediatric surgery, neonatology, cardiology, etc., as many as you can think of, and sometimes you've got to carve it to the specific patient. Inviting them to meet with families to create plans is important. As part and parcel of those evaluations, we can do prenatal imaging to find out the severity of the defect, the associated anomalies, evaluate the heart, genetics. Having good, sound, multidisciplinary prenatal consultations with family allows families to make informed and rational choices about where to deliver. Sometimes an isolated defect might be delivered at a small institution, whereas a complicated one might need to be at a tertiary care center. Mild versus severe defects with the possibility of ECMO should ideally be delivered at the tertiary care center. Antenatal testing, fetal intervention, and research endeavors are all things that families can deliberate on before the baby is born. In choosing a fetal center, families often consider centers with high-level integrated prenatal and postnatal care, where the care is seamless, where the centers are experienced and have a proven track record, both for research, innovation, and ones that follow clinical care guidelines, ones that have an infrastructure that cares for both mom and baby. At Texas Children's, we follow much of the same with the multidisciplinary care. We are also a center for fetal intervention. We do have the multidisciplinary planning that I alluded to earlier. And I'm not going to share during the talk details about that, but for those who are interested, the Fetal Center website has both the details as well as data of what we do and have done. At Texas Children's, in terms of follow-up, in 2018, February, we began our CDH Outcomes Clinic for the stable patients. And then 2019, April, the Complex Care Clinic for the ventilator and or oxygen medication dependent patients. Follow-up and referrals as needed. Follow a schedule in the initial year every 3 months and less often as babies get to be older, all the way up to 18 years and hand off to an adult physician. Measurements of growth, chest x-rays, etc., all part and parcel of these evaluations, as are referrals to the multiple consultants that might need their care. Over the session so far, I've tackled the elements of a high-functioning CDH program. I've shared with you some insight about how healthcare operations can promote quality-enhancing processes. I've shared with you, in terms of the outline, the aspects of the high-functioning program. Let me delve next into problem-solving and QAPI. This quote by President Emeritus of the IHI is very apt. Every system is perfectly designed to get the results it gets. The results you get today are because of the system you have today. To know where to focus your attention and where to place your efforts for quality improvement requires periodic review of metrics. They are vital for knowing whether you're on track, as well as for identifying opportunities of where to focus your attention. The need for a QAPI is vital. Attributes of good metrics for QAPI. QAPI stands for Quality Assessment Performance Improvement. Attributes of good metrics for QAPI are they need to be transparent. People need to know what you're measuring. They need to be ones that will foster collaborative teamwork, and they need to be ones that can foster solution-focused problem solving. Let me expand on this for just a bit. In the industrial age, people talked about quality assurance, where gadgets and machines or cars came off a line and they were measured against certain standards, and compliance of the workers were measured against desired metrics. In this modern age, we talk about performance improvement, which is a continuous process. We want to get better day by day. QAPI essentially seeks to combine the two, whereas we want to define the metrics we want to aim and strive towards to try and figure out whether we are achieving them, as well as we want to seek the performance improvement that will continually build on getting better. QAPI recognizes individual fallibility, none of us are perfect, and helps to build the safeguards so that the system itself works better. To identify areas for QAPI, one might choose to look at the 6 Institute of Medicine dimensions of quality domain. Alternatively, you could choose and create your own program-based quality triggers, KPIs, or key performance indicators. You might also find incident reports where caregivers might report something did not work well or did not work the way it should. Alternatively, quote unquote, customer complaints, families, referring docs, people who make complaints about something that they encountered might serve as identifying an area for QAPI. Whilst I don't have the time to expand on QAPI, allow me to share with you the Fernandes QAPI paradigm. I believe that QAPI requires the interplay of evidence-based medicine, applied statistics, and applied human psychology. Let me explain what I mean by that. To improve the quality of care that we deliver, we must start with evidence-based medicine. Over and on this, we need to use applied human psychology. Let me explain how we did this and how it can be done. The EMR, the electronic medical record, is a good example of how applied human psychology helps improve the quality of care. By creating order sets, for example, if I've got an order set of 20 individual orders that are evidence-based that I'd like to deploy for the care of my CDH patient, it's more likely than not that the practitioner at the bedside is likely to click one button and say yes, accept, and deploy the order set than they are to actually enter 20 different orders individually that they've got to remember and copy from a paper sheet elsewhere. Situations like this can and should be sought out of how to make it easy for the frontline worker to do the right thing most easily. Let's talk a little bit about statistics, and I've got an example further as well. Applied statistics refers to the Pareto principle or the 80-20 rule. Through all the QI measures, attempt to focus attention on the areas where you get the most bang for your buck. To be able to do that, we apply statistics to find out the 80% that cause the 20% of the problems and vice versa, to know where one might focus one's attention. The VA Quality Scholars Model for Improvement allows us to find aims for individual team members to work on, to talk about, to work on, to plan, do, study, act, to improve the quality of care delivered. Whilst I don't have the time in this talk to delve into this further, I'd probably share with you an insight that's best stated by Edward Deming in terms of reducing variation. If I had to reduce my message for management to just a few words, I'd say reduce variation. Let me share with you a cartoon that I created to illustrate how reducing variation improves the quality of care. On the x-axis, I've got % compliance with evidence-based guidelines, going from left to right, greater compliance of guidelines, from no compliance to almost all compliance. And on the y-axis, I've got improving quality of care, going from bottom to the top of improving quality of care. The individual dots and the bars represent individual team members' compliance with the quality of care. As more and more individuals seek to follow the evidence-based guidelines, the overall quality of the care delivered improves for the program as a whole. Now, guidelines are meant to follow about 80% of the cases, so we never, at least in our practice and my practice, insist that something needs to be done. The 20% of cases where somebody might choose to do something different allows us to question whether the guidelines themselves need to be modified. In this case, one can see as one goes from less compliance to more compliance, the bars of the quality of care and hopefully the outcomes decreases, and the median increases. The quality of the care afforded by the program improves. Let me end on this note by saying that this needs what's termed as a growth mindset. For quality improvement efforts to work, teams need to develop a growth mindset where they're willing to learn. If somebody's stuck in a fixed mindset, as alluded to by Carol Dweck in a book, Mindset, we would never be able to achieve any quality improvement. And Henry Ford said it best, the only real mistake is one from which we learn nothing. At Texas Children's, we've got a whole slew of quality improvement efforts ranging from data collaboration of the different data sets that we've got, quality improvement across the spectrum of prenatal, postnatal, and outpatient, revising management guidelines, trying to attempt to improve on what we currently do, outreach with creating a program website, follow-up clinic. In terms of outreach, I've shared with you earlier the Baylor guidelines where you could obtain your own copy of what we do, hopefully to see what others do. In terms of education, our internal conferences, guest speakers, M&Ms, where we learn from what's happened and had adverse outcomes. And then hospital-wide initiatives in terms of standardizing order sets. And for example, neuromonitoring, which is a recent change we have of babies going on ECMO. I hope with that I've covered the first bullets. I'm going to touch upon briefly the last point in terms of transport. Ideally, babies with diaphragmatic hernia should be born at institutions that are ready and prepared to care for them. However, that's not always possible. To be able to make that happen, you need to establish good referral networks amongst the community, referring docs, OB, MFM, neo, pediatric surgery, etc., and identifying patients who could ideally be transported in utero to a center that could care for them the moment they're born. Sharing educational materials and CME opportunities like this one that Dr. Ali and Dr. Cass have initiated. Supporting referring hospitals in real time. If we get a call, we need to be on the phone and help them care for that child. And then providing them feedback on patients that they refer, and then possibly sending patients back into the community as appropriate if they no longer need the tertiary level care of a tertiary institution. And with that, I'm going to end and invite you to share your own thoughts about this topic. Thank you.